blowing my own trumpet, but somebody told me if you can't blow your own trumpet, who else will blow your trumpet? So not because I had to blow my trumpet, but I just want to tell, I met so many people, and whenever I read this article, I remember that particular photograph I put there. Just though 50% is just to show off that I met the people, the remaining is just to meet that if you can't meet those people, at least you meet those people who have really done well. So every article I read, oh, I met Lehman, let me put here. We can meet Olsky, let me put there. These are all the people I met. So don't think that I'm just showing off, though it's also part of my presentation, but it will be a little bit of this is okay. Having said that, I've talked about myths in pediatric anesthesia. I think it's a very difficult topic, which I thought is, I will put you into some things, okay. The first thing is that experience, you call talking about EBM. EBM is, I feel it is an experience-based medicine, which I have done the last 30 years of pediatric anesthesia. And what I have thought about 25 years ago is come now into publications. Okay, so I am just transferring whatever I thought has come to publication and make it as evidence-based medicine. So I am going to compare my experience and with the published articles right now and see what is really is happening. Whatever I thought is myth is now becoming a reality now in publications. That I'll let whatever is possible. So I'll get about. So please think, all of you, please think critically, okay? You have to think a little bit. You little yoga. There are lots of misconceptions which in the past has become a dogma now. It's very, very important. Think like that. We today pick up 4 areas. If there is a time, I'll do 4 areas. If there's no time, I'll with 3-1. Where it may not be exactly what you thought. There's something changed really in this which is okay. It is not because somebody has told, because I have experienced, and that has come into publication, and that is the effect of the patient. That's why I'm doing this. So the first question is, I'm going to put one question, and I'm giving a talk on that particular concept. After that, I want to know how many have changed after my talk. But there's no compulsion you have to change after that. You still be the same what you are. So sevoflurane is better than halothane in pediatric anesthesia. Myth or truth? Time starts now. Okay. See, halothane was introduced in 1956, and sevoflurane was released in Japanese market in 1992, and it became the induction of agent choice in most countries compared to extremely cheap halothane. Okay. The cardiac arrest due to medication has decreased from 37% to 18% from 1994 in 2000. And this is from the article from the POCA registry. I know the chairman is Chandra Ramamurthy. She's from Jibmer student, and she's the chairman of this particular registry. And everyone refers to this whenever we talk about cardiac arrest in children. And she's in California, and that particular one, they all relate to halothane. How is it? I don't know, but it's just no real evidence that's related to halothane. Please take a think. That's why I told please think critically. But they have no evidence that it is because of halothane. But they interpreted it could be because of less use of halothane. But please remember, the experience of the anesthetic has become all right. Monitoring has become better. So you can't just put a halothane as the cause for that. And this is a beautiful article from Olsky from Germany. This is the one research done on pediatric anesthesia, and I just want to please think that everybody says sevoflurane is a better cardiac stable than halothane. What they compared is not the MAC. They compared the dial setting of the dial setting, and that's what's happening is 5% of this one 8%, whereas 5% MAC is 5.75 is halothane. Sevoflurane 8% MAC is only 2.42. They're not compared the MAC value. Please remember this. So adding nitrous oxide will decrease the MAC of halothane by 70%. Adding a nitrous oxide sevoflurane will decrease only 20%. So adding nitrous oxide, the MAC values also differ. So you cannot really think the cardiac depressant effect is because of sevoflurane. I have personally made that put 8%, I found the BP is going down to 20 in a small baby. So if you don't know how to use sevoflurane, still there is a cardiac depressant. There is only one study, please remember this, there is only one study from Japan has compared the equipotent dose of MAC of sevoflurane with halothane, and they said no difference in the hemodynamic stability between halothane and sevoflurane if you compare the MAC. Okay, so I think so, but sevoflurane you think of rapid recovery. And after that, the child is restless and you don't know what to give, and that's, do you need this emergency delirium? You don't need that. So I feel when you think of back and tell them, I spent with Ryan Cook about 20 years ago in Pittsburgh in the daycare surgery. He's written a book on Paediatric Anaesthesia handbook by Ryan Cook. His son is also pediatric anesthesia in Pittsburgh. And he was doing tonsillectomy, and he said, come, every time I spend about 20 days with the Pittsburgh, he says, you come inside, he shows me. And this is the picture I took in the United States about 20 years ago when halothane was not there. There's an halothane, enflurane, and sevoflurane, and this fellow was using halothane for tonsillectomy. And I asked him, I thought you don't use halothane. He said, no, Ramesh, we are happy with halothane. The agent doesn't matter, and the person uses that matters. So don't think sevoflurane is safe, and using it you are getting into problems. That's important things. So critical appraisal, please think, do we critically analyze the difference between the drugs? Because somebody is published, you read it and use it, but you don't critically think whether it's really okay. Or they clinically have significant benefits. Do you think like that? When I went to Australia maybe 10 years ago, Ramesh, you come, why don't you bring halothane with him, 3 bottles? So they want halothane, you use it, but they don't get halothane. That's what is important is. Is the recovery room agitation necessary? You give sevoflurane, they're restless, again give some sedation. Do you need that? I don't think so. Or the cost justified if the resources are limited. We wanted the sevoflurane, the cost of anesthesia is about 10,000 rupees. Use halothane, it's less than 2,000 rupees. It's really needed if you can use it very well. There's no report of halothane hepatitis in children. There is no there's a problem with halothane I reported. Why do you want to just because sevoflurane and get into the problems? All right? Okay, the question starts now, please. Okay. Is sevoflurane anesthesia better than halothane in pediatric anesthesia as a myth or a truth? Don't believe my talk, okay? Yeah. This is the comparison that she's still there. I think they have not. I'm very happy the talk has not influenced anybody. Okay, I think that's very good. But I just want to tell you that it's more or less the same, and it's really happy that it's okay. But I just want to tell you the talk has not influenced. But anything change in that? Oh, the color has changed. Oh God, I didn't know that. Huh? Yeah, I was a little depressed. Now I'm happy now. No, I don't know. Please think critically. If you think it's all right, I think that's very important. Please don't. The way I'm telling is very, very important. I found that people are putting sevoflurane is happy and put 8%, trying for IV line, spend 10 minutes, that it is not cardiac depressant. When I go there, the child is already arrested. So don't think that sevoflurane is a very, very good drug. Please be very happy about it. Okay. Please, okay, coming to the second one, okay? The Crackard pressure and the RSI are recommended in children to prevent regurgitation and aspiration. Myth or truth? Time starts now. Okay, it's a myth and it's a truth. Okay, right, okay. Coming back, I'll do this, okay. Crackard pressure was done selects in the Lancet, and it is only a woman who is pregnant, ether anesthesia, head-on position, and ether was used at that particular time. So 1960s it was introduced. And lots of papers in cadavers where seligman were compressed esophagus, but there's a lot of difference between cadaver and living objects. Please remember that. Cadaver easily, I'm sure that Rapek is nodding his head because he had a lot of work on cadavers. It's easy to do that, but you can't interpret. Cricket pressure. Someone giving cricket pressure, if you can't ventilate or if you can't see anything, you release the cricket pressure. If you can't do it, please release it. Then what is the use in giving a cricket pressure? And too early, too hot, too sharp, no real data to see how much a cricket pressure to be used in children. Because there are a lot of saying 2 units, 5 Newton. How much you can measure? 2 Newton, 5 Newton, I don't know. So there's a big, in 2003, there is an article where they put in the MRI and try to press the cricoid and see that what's happening in the cricoid is that esophagus is not compressed, but it is pushed little laterally. So I think that's a very important, that it's not putting compressed, but it's a big article on this. If you say it's very useful in children, which I will want to tell you this. So this is actually Lerman from Buffalo, and this article at the end said, may the force be with you. Despite almost 5-decade history of the cricket pressure, the level of evidence to support the effectiveness of preventing passive regurgitation is paltry for resulting in the great recommendation for use. So I think it's a very, very important thing. It has not been used at all and not very useful because you don't know exactly the force. So coming to the rapid sequence induction, pre-oxygenation is very difficult in a baby. They move everything. Where do you want to give pre-oxygenation? Cricket pressure, when you want to give how much, it's very difficult to give exactly. You want to put the child to sleep, then you do it. It's very difficult. Apneic period, how long you can give it? You want to give high flow oxygen, you can put long, if otherwise you have to choke it. Aspiration is very, very, very rare children. I can tell you that aspiration is very rare children, even in an inexperienced hands, it is very, very rare in children. So there's a beautiful article, Complications During Rapid Sequence Induction in benchmark study. This is a beautiful one. It doesn't tell you anything, that is the complications almost nil. And this by this Walker and all, that they did a cricket pressure, put a bronchoscopic assessment, and they found how much Newton is needed, and it's very, very variable. Sometimes 5 Newton, sometimes it's about 15 Newton. So it's very variable, so exactly you don't know what you are giving. This is a Brock Cutness from Paediatric Anaesthesia. It's a beautiful editorial. Is cricket pressure necessary? Which is really is okay. And for this, they've changed the rapid sequence in a different form. It's called the modified RSI, or it's called a controlled RSI. I'm talking about the PGs because if you go to the exams, because people will say, do you want RSI? You will have to say RSI, otherwise you will be failed. Because as a modification, because people should know that things have changed. It has completely changed to modified RSI or a controlled RSI. That means you can oxygenate, and a lot of things are that you can ventilate gently. There's no apneic period. You can give a muscle relaxants and little bit of a, so no cricket pressure, you intubate. I think that's a modified RSI. We can read this. So controlled RSI is no cricket pressure, not to inflate the stomach. You give it to any of the resident, you will ventilate with a lot of pull like this. More stomach will go, not go oxygen. So you just gently ventilate. I think that's the important thing. And do not do laryngoscopy when you the most of the problem occurs when you do a laryngoscopy and lightly anesthetize, you will vomit. See, when you vomit, because it's light plane. So good plane is very important, deeper plane, and cricket pressure does not prevent forcefully. If the child vomits forcefully, cricket pressure is not going to help you. It will prevent only a passive regurgitation. So cricket pressure, don't do it, and you can do that. So now, question starts now, okay. Cricket pressure and RSI are recommended in children to prevent regurgitation aspiration. Is it a myth or a truth? See, what is this? I'm not able to see that. This is, huh? This one? Oh, okay. I think. No, no, that's okay. Leave it. That's okay. That's okay. That's all right. That's okay. That's okay. That's okay. Leave it. It's okay. I'm all right with that. See, I don't want that my talk is a success. That I don't want to do it. I want to pass on the concept to you. That's all. It's okay with me. But I want to tell you that please listen to me. I may be fast, but I just. No, that's okay. But as long as people generally agree that credit card pressure is not very useful in children, RSA is not recommended in children, I have done my job. That's okay. I don't want to vote it. I think that's what is important. It's okay with that. I do it last 20 years, but in 2017, it has come in the publications. That I just want to tell you that what experience has made really now in the last 20 years. Okay. So the next, third one, I'm sure is okay with that. Bala, can I have 5 more minutes? The last one I just finished is okay. Otherwise I'll stop like this. Cough tubes should not be used in children less than 3 years. Is it a myth or a truth? Time starts now. Okay, 50-50, I think that's all right. I think it's understandable. Let me see that. There's a beautiful article by Cough Tubes in Children, Things Have Changed, by Marcus Weiss and Andrew Gerber. They are the one who have patented the microcuff tube, Kimberly Clark from Zurich. I spent about a month in Zurich. Actually, I stayed with the Gerber's house for a month. He was very hospitable at that particular time. In this hospital, you can't see uncuffed tubes in this hospital. I believe me, about 2 years ago, no uncuffed tubes in children. This is the one, lot of articles. Marcus Weiss and Andrew Gerber are the persons who have designed this Kimberly Clark. Now Kimberly Clark patents they've gone to Aldi or Always, something like that. And this what is a microcuff tube is a no Murphy's eye, and it's very thin. It's only about 0.4 micron, where other cuffs are all 70 microns. Don't use other cuffs tubes. Let it be Portex, let it be anything, Rush, but don't use it. I don't mind if the company people are around, because it is not recommended at all. If you want to use a cuff tube, use a microcuff tubes. The advantages are that tube changes are you put 3 size bleaking, then 3.5, 4. So too many tubes are not available. Accommodate different sizes in a very nicely if you have a microcuff tube. IPPV easier and it's uniform. Monitoring is better because you want integrated carbon dioxide. Then the pollution is not much because you want thinking of pollution these days. The pollution is not much. We are using an expensive drugs like sevoflurane and low flow anesthesia. So cuff tube is definitely much better. And pulmonary aspiration there's no really evidence it prevents it, but it's little minimizes with the cuff tube, which is okay with that. And that's why I'm telling you, all cuff tubes are not the same. You see, microcuff tube is a very short if you want to use it, use microcuff tube. In France, Isabella Murat, I had been to Lausanne, the retirement party of Isabella Murat, and that particular paper is about 15,000 children, nil pollution, and they stopped buying uncuffed tube all stage in France. And I think that's what Isabella Murat is one of the top person who have done a lot of work on this. And this is Maxwell from Philadelphia Children's Hospital, and this cuff tube was a debate should finally end, and this, if you want to use it, use a microcuff tube, and that is the one it is recommended. And if you want to use microcuff tube, please remember for a long term continuous cough pressure monitor. If it is not available, you can use intermittent cough monitor. Use a microcuff, please monitor cough pressure, because Ramesh said don't start using tomorrow, but please measure the cough pressure. So cuff tube should not be used in children less than 3 years. A myth or a truth? Okay. No, the problem is I'm not, because usually what I do is I put on the left side the previous one right side, and I am really very slow in IQ is very slow, so I just have to think of things. Okay, and Bala helps me out, you see. So I think that's very important, that the message is that cuff tubes can be used in children, and if you want to use cuff tube, use a microcuff tube, and use a microcuff longer time, please monitor cuff pressure. I think these are 3 points. I just want to do that. Okay. Final one, I might take 2 minutes more. We follow following guidelines for the fasting is 8 hours solids, 4 hours milk, and 4 hours 844 is the clear fluids, or use 644, 642, or 641. Time starts now. In children and infants. I think that is very good, because most of them, they follow this. But I'll tell you how this has changed. I'm going to tell you this one is okay. First guidelines by ASA is 1999. And why do we need pre-op guidelines? And how much acid aspirin is needed to cause damage is 0.4 ml per kilo. This is a common question. Examiner asks how much you will aspirate. They say 0.4 ml. That 0.4 ml, 0.8 ml has been given in the animals, not in man. So you want that answer so that to give a pass. I think that's wrong. The fasting, if you want the history of fasting guidelines, is a beautiful article. Fasting from midnight, the history began dogma by Roger Maltby, where he has said what is the new guideline, even this 2 hours, even in 1883, Lister has done it. This is nothing that it is new in 1991. So this is a beautiful article, it gives you all the things is okay. And there's a beautiful article, perioperative pulmonary aspiration in infants and children. Warner, maybe daughter-in-law, daughter, grandfather, and all this. So it's all, five Warners are there. I met one Warner, David Warner, he's from Mayo Clinic, and he's the one, and he says 63,000, and of the 63,000 is a good number, only 8 cases of aspiration, and all the 8 cases had some sort of systemic illness. So this is a beautiful one which refers, there is no aspiration. Even my own, and touch wood, there is no aspiration. I have done a lot 30 years. I have taken with 20 minutes, 30 minutes, no aspiration has happened. I can tell you that. So if you want aspiration injury to occur, there will be probability, there should be something in the content, and there should be probability you should regurgitate, and there should be probability you should aspirate, and that aspirate should be probably should got damage to got aspiration pneumonitis. So these probabilities are very, very less. So Mendelssohn's and all these things have done aspirin pneumonitis a long time ago. All these things are animal experiments, and all this ASA guideline 2011, and then this was 1999, and this guidelines was given, that 642 was given, and this is as a Crenshaw, who is a nurse in Houston, and done every 10 years you should see whether they are following the guidelines. All of them said 90% of the children they've kept NPO. Even in US now, I'm not talking about late, and fasting practice is not improved, and they always fast more than the safe minimum guidelines. It's in Texas. So what is old habits die hard? I think that's what it is. So the Thomas Inglehart is a beautiful article. Even he is in Scotland. Even in this, minimum fasting of solids is 12 hours. Minimum fasting 5 for liquids is 7 hours in children. Not in the UK now, which is being there. And this is actually Smiths have done a lot of work, and they found whether you fast for about 2 hours or 1 hour, the gastric volume is the same, gastric pH is the same. I think this is a beautiful, but a lot of articles are there. So I want to conclude this particular one, that safe anesthesia technique is the precondition to avoid perioperative. Safe anesthesia technique, I think this should be 100% important, nothing else. Fasting longer than recommended before elective procedure does not improve the safety for otherwise healthy children. Research suggests 1 hour. Okay, I'll tell you, research suggests 1 hour, but still they're coming down. Shorter fasting times may improve the comfort, especially during organization delays. This happens many times in the hospital. That's what I follow. I told them, don't write NPO guidelines. This is, I am true. What I do is give tender coconut and keep it in the hospital, give it as much as possible. Next case, when I'm going to take it up, I tell them, please stop at that particular time. This is called fasting on demand. I think future it is going to be fasting on demand, because you child fasting 6 o'clock and the first surgery goes for 3-4 hours, you don't know whether to take it up or not. I think if you want to do it, you can use a fasting on demand. That I started doing it. Probably next lecture will be like that. So we follow the 5 guidelines. The question now. Start. Okay. Okay, somebody can go up to 1 hour. I think 1 hour is not bad. I'm going to tell you, 1 hour is not too bad as long as a clear liquid. Because that's a very, because if it's milk, you are in trouble. So clear liquid and safe anesthetic technique, I think that's probably, it's a very safe in a good one. I just want to conclude. I just want to conclude this. That sevoflurane is a good agent for use in children, but halothane was unnecessarily blamed. I think that's my conclusion that particular time. You can, my father always says, say the good thing. You know, in Tamil, I don't know how many is okay. My father is Appa, they call Appa here. Appa illiya. My father used to say, why can't you ask Appa irkangala? Both are same only. So positive is very important than is a negative. Why do you want to blame halothane if you want to give sevoflurane? Okay, don't blame halothane. Crack pressure RSA not recommended in children. It's not recommended in children. That's very clear. Cough tubes can be used in children with microcough and cough monitoring. And finally, aspiration is uncommon in children and fasting times can be reduced depending upon the expertise. I think that's very important because I tell you 30 minutes tomorrow, don't do 30 minutes and give unnecessarily, put a laryngoscope, you vomit and then aspirate. I think very important, your expertise makes all the difference in that. So a humble request to all the people. This is a humble request. Do not believe everything you read or told in a conference without considering whether it makes sense and is logical, and always have a reason to do that. I think that's important, that whatever I do, whatever you tell in the conference, doesn't mean we are given a podium chance, doesn't mean I am 100% all right. There are better persons in the audience. Plus you think whether it's useful in your particular one and see if that is all right for you, and please use it. Thank you, Bala, for giving me another 5 minutes of your time.